So let us study about the clinical feature of RCC. So any cancers, we classify the clinical feature as local. Local means local clinical feature. That means due to the presence of cancer in that organ itself. Uh, locally advanced. Locally advanced means if the cancer spread to surrounding structure, there are some specific, symptoms they produce. Metastatic. Metastatic. If they go to other organ, they produce different type of symptoms, and some are special type like uh, paraneoplastic. Neoplastic, not found in all cancers. Paraneoplastic symptoms. Okay, here we'll discuss according to these headings. Okay, let's see. One of the most common symptom is hematuria, and I've already told you in malignancy in very early stages, even in the locally advanced stage, it is painless. So and it is gross in nature. Gross means they can see. So patient can see hematuria in the urine. So usually it is gross. Total means from the beginning to the end of micturition, entire urine is red. So it is total gross painless hematuria. Okay, so hematuria is one of the most common feature of RCC. Okay, sometime patient may come to us with a triad of symptoms. Triad means three symptoms together. Okay, uh, those are gross hematuria, flank pain, and palpable kidney or palpable mass. That means see, suppose there's a kidney tumor, RCC, not that much big. Okay, so you cannot palpate the tumor or kidney itself. Okay, if it is too big, like it's very big, okay, kidney become also enlarged and tumor become enlarged, then you can palpate from outside. Palpable. And obviously when it is very large, it invade the surrounding structure, causing pain, and there will be hematuria. Okay, so when you find a patient with all of these three symptoms, that is hematuria, flank pain, and palpable tumor. So if a patient come to us with the three symptoms, all these three features, okay, gross hematuria, flank pain, and palpable kidney, that is known as too late symptom. Too late symptom. That means the patient already had at least local advancement. Okay, and this is not common. We find these too late symptoms in only 10% of cases. Mostly we find gross hematuria. Okay. Sometimes palpable mass, but all these symptoms or clinical features are found that is known as too late symptoms. Okay, because it indicate advancement. As I already told you, we can classify the clinical feature as local advanced, metastatic, and inferior vena cava obstruction. It is due to local advancement. I'll explain it. And paraneoplastic syndrome. Okay, just see over here. There are so many paraneoplastic syndrome. The most common one is increased ESR value followed by hypertension. It's okay, remember that. I'll explain everything, don't worry at all. See, let us see the feature one by one. Sometimes, patients are diagnosed incidentally. That means they don't have any symptom. They went to the doctor for any other reason, and during scanning process, ultrasonogram or CT scan, he was diagnosed as a case of RCC. This may happen. Okay, but if they present to you with a symptom, the most common symptom would be hematuria, gross painless hematuria. Okay, but sometimes they come to you with all these three combined feature. Okay, that is triad, hematuria, flank pain, and abdominal mass. This is known as too late triad or too late symptom, indicating advanced disease. And if the RCC metastasize to other organ, then depending on the organ, it produces symptoms. For example, I've told you the most common site of metastasis is lung, right? Lung. So if a cancer go to lung from kidney, obviously it produces cough and hemoptysis, chronic cough and hemoptysis. Hemoptysis means coughing out of blood, coughing out blood. Okay, they will cough out blood. And if it goes to bone, it could be vertebral bone, it could be limb bone, then the patient complains of bone pain, especially back pain or long bone pain, and sometimes they lead to fracture of bone fracture because of osteolytic nature. It destroys the bone. Okay, if it goes to brain, if it goes to brain, then you know what happened. They will complain of a severe headache, obviously vomiting also. But later on, the patient may present to you with convulsion or seizure, convulsion. These are the feature of brain metastasis. Okay, so it can go to liver. It can go to liver and can produce, if there's extensive damage of liver cells, it may lead to jaundice. Okay, and due to metastasis, there are some common symptoms. When there's metastasis to any organ, it may lead to some common symptom like asthenia. Asthenia means weakness. Anorexia means loss of appetite. Patient don't want to eat. And anemia. These are the general features of metastasis. Just we remember as AAA, AAA. Asthenia, anorexia, anemia, and don't forget about weight loss. These are very significant weight loss, like more than 3 kg in 3 months or more than 6 kg in 6 months. Rapid weight loss. These are the general features of any cancers. Okay, so this is found in RCC, liver cancer, whatever cancer is. If it is metastasized, then these are the general features of metastasis. So depending on the organ which it involved, we have different symptoms. Obviously, the patient will have hematuria, no doubt. In addition to hematuria and or the flank pain, they will present to you with these additional features. Okay, that's why whenever you examine a patient of cancer, always ask these symptoms. Do you have chronic cough with hemoptysis? Do you have back pain, bone pain, recently onset? Okay, so these things you have to ask, and you can have an idea clinically there could be some metastasis. Okay, now there's a special mention over here, that is inferior vena cava obstruction, because let me show you why. See, this is kidney. Wait, use different color. Okay, this is kidney. Okay, fine. So this is kidney, and just I'm drawing inferior vena cava. We know we have aorta also, but here as I have to discuss inferior vena cava, so I'm drawing just inferior vena cava. Okay, see, the renal vein from both sides, it drains the blood from kidney. Okay, but the cancer also follow the same pathway when it want to metastasize. So it follow the renal vein and go to inferior vena cava, and if it is big enough, the thrombosis, the tumor thrombosis is big enough, it can obstruct the flow of inferior vena cava while going up. Okay, going towards the heart and lung, it may obstruct the inferior vena cava. Now, how we will know that there is a obstruction in inferior vena cava? We have two clinical features. Number one, as you know, this inferior vena cava is also receiving the blood from leg, right? Lower limb, via femoral vein and external iliac vein. Okay, lower limb. So when there's an obstruction of the blood flow from the lower limb, it lead to bilateral leg edema. So the leg will be edematous both sides because there is obstruction of flow of blood in inferior vena cava. Okay. And one more thing. That is, if the patient is male, you know that the testis of male, okay, the male testis, you know, okay, male testis have those testicular vein known as pampiniform vein. These vein is actually connected. Please remember this one. In the left side, they drain to the renal vein. Okay, left testicular vein, or you can say gonadal vein, drain into left renal vein. Okay, this has importance. I'll explain later on when I teach you varicocele. And in the right side, these testicular vein drain directly into inferior vena cava. Okay, right side. So please remember this one, commonly asked in the exam. Whatever the drainage is, if there is an obstruction of these inferior vena cava by a thrombus, then what happened? These vein will be engorged because the blood is not going there accurately. So causing varicocele. So whenever you diagnose a varicocele in elderly population, like 50s, 60s, in that case, try to identify whether there is RCC or not, because this varicocele may be the manifestation of RCC involving the inferior vena cava. If the varicocele is you found in the very young patient like 20s and 30s, so you not think about RCC. But if a patient comes to you, elderly patient, male, 60s, and he's showing varicocele, in that case, try to identify whether he has RCC or not. Well, how would you do that? You can do at least ultrasonogram of abdomen. If not, then you can go for a CT scan. Okay, and obviously try to ask the other question, like try to identify hematuria or not. Okay, this is important. So obstruction of inferior vena cava is seen clinically as bilateral limb edema and varicocele, non-reducing varicocele. Okay, fine. Now there's one more special symptoms or syndrome known as paraneoplastic syndrome, found in around 20% of RCC patient. What is paraneoplastic syndrome? To understand that, first of all, you should understand this thing. Wait. Fine. Suppose there is RCC. And when there's RCC, I've already told you the most common symptom is hematuria, right? Hematuria. So if I ask you why there is hematuria, you can say, sir, because the RCC is a cancer cells. They are very fragile. They are very vascular. When they break or when these artery erode, there will be hematuria. So you can explain hematuria. How you can explain? Because of the cancer location in the kidney, right? Second thing, can you explain a patient of RCC having cough and hemoptysis? Yes, because I can say fine, RCC patient, if there's a metastasis to lung, then the lung, obviously, it will destroy the lung tissues and cause bleeding, causing hemoptysis. I can explain this as well. But can you explain why there is Cushing syndrome? Cushing syndrome in the patient of RCC. You cannot explain due to locally presence, or you cannot explain due to metastasis. So whenever a symptoms of cancer cannot be explained due to its location or metastasis, then we say it is a paraneoplastic syndrome. It is usually due to some hormones or chemicals, substance released by these cancer cell. For example, in the case of Cushing syndrome, why there is a Cushing syndrome in the case of RCC? It is due to release of ACTH, adrenocorticotropic hormone like substance from RCC. So whenever you cannot explain the symptoms or sign due to presence of cancer in that organ or metastasis, then it is paraneoplastic. Para means additional, paraneoplastic syndrome. Okay, so RCC has a lot of paraneoplastic syndromes. I've just focused on few. One is hypercalcemia. So these cancer cells produce parathyroid-like substances. And you know what does parathyroid do? Parathyroid release calcium from bone such that it lead to hypercalcemia. Hypertension, because of excess production of renin from the cancer cell. And you know what is renin? Renin angiotensin mechanism. So excess renin activate angiotensin mechanism and leading to hypertension. Polycythemia. These cancer cells release erythropoietin-like substance, and you know erythropoietin is a inducer of RBC synthesis in bone marrow, and it lead to excessive amount of this RBC synthesis and lead to polycythemia. Okay. It may lead to Cushing syndrome due to, I've already told you, ACTH-like substance secretion. It can cause galacturia. Galacturia means secretion of milk-like substance from the male breast due to excess amount of prolactin. Okay, it can cause male breast enlargement, that is gynecomastia. That is due to some excess amount of gonadotropin-like hormone release. Okay, so these are the things, okay, which can be explained by some chemicals or hormones released by cancer cells. And there is one interesting syndrome known as Stuffhouse syndrome. What is that? This is actually a liver dysfunction, which is reversible liver dysfunction. Why I'm saying reversible? Because if you treat RCC, these problems will be reversed. So this is a reversible liver dysfunction. Okay, usually it presents as obstructive jaundice. Okay, the patient have all the features of jaundice. You know, the bilirubin is increased. Patient have a jaundice. They might have mild fever. All are you know showing us feature like liver dysfunction. It is due to some chemical release like interleukins and CSF, means colony stimulating factors. Okay, it released by the kidney RCC, and usually it subsides after nephrectomy. So, okay, so this is not due to metastasis to liver. Liver is clean, but there is a liver injury due to release of some chemicals like CSF or interleukin. So these are known as reversible non-metastatic liver dysfunction. Okay, Stuffhouse syndrome. So remember that. So these are all paraneoplastic syndrome found in around 20% of patients of RCC, and these all paraneoplastic syndrome will be reversed when you do nephrectomy or remove the cancer cells. Okay, so I know it's very difficult to remember all these things, you know, but see, not all the cancers produce hormone-like substance. There are few cancers in our body. So RCC is one of them. Another one is lung cancer. So whenever you are studying these cancer where there's a release of these hormone-like substances causing paraneoplastic syndrome, you have to know this because it helps in diagnosis, you know, and it also helps in prognosis, if there's a recurrence or not. And moreover, for you guys, it helps to pass your exam with good numbers. Okay, so please remember these paraneoplastic syndrome. Okay, sometime asked in exam. Okay, now let's see the MCQs. Please solve it, guys. So painless gross hematuria is found in RCC, right? No doubt. Stricture urethra is painful, maybe no hematuria at all, bladder stone painful, polycystic kidney disease, just when the cyst rupture there is a pain. But RCC is clean, painful hematuria. This one. Yes, RCC is associated with hypercalcemia because of release of that parathormone-like substance. Yes, there is polycythemia due to release of erythropoietin. There is Cushing syndrome due to release of ACTH. So all are correct. So RCC can cause all of the following, right? All of the following. So other tumors, but see, cannonball metastasis means this very special type of metastasis where you can see the lung has the round white opacities in X-ray or CT scan, just like cannonball. Cannonball is what is cannonball? When there was a fight between two countries like 30, 40, 50 years back, they used to use that cannon, right? These are the cannonballs. The round opacities are found in lung, and this is usually commonly found in RCC and seminoma of testis. It is a cancer of testis. We'll discuss later on. Okay, remember that. Not correct regarding RCC. It can associate with varicocele. I've already explained. If there's an obstruction of IVC, it can cause varicocele. It may involve renal vein because the thrombus go through the renal vein. Okay. It arises from proximal tubule. Yes. It is common in female. No. Male is more affected, either 2:1 or 3:2. Right. So male chance of RCC is more common in male than female. So the wrong statement is B. Oh, so C. More common in female. It's wrong. Okay. This one. You all know this. The most common feature of renal. See, the question is renal adenocarcinoma. So renal adenocarcinoma means RCC. Okay, just giving you a different name of same disease. Okay, renal adenocarcinoma means RCC. So the most common feature is hematuria. Fine. So I hope you have understood something. Okay, till now. Now let us study how to diagnose suspected case of RCC. Okay. So we follow the same pattern for all the cancers. First of all, we think what are the investigations for diagnosis. Okay. Second, once we diagnose, then we have to think about metastasis. Always think about metastasis in cancer. So you have to do some metastatic evaluation. Some are routine, we always do. Some are very specific, we only do whenever required. Okay, and there are some general investigations which is always done for fitness of the patient, like CBC, urine routine, ECG, echo, and those viral marker scannings. These all are done to any patient who is undergoing major surgeries. Okay, so that I'm not going to explain over here because this is, I think you have already studied in your first semester. I'll more focus on how to diagnose and how to evaluate for metastasis. Okay. For diagnosis, we can do ultrasonogram of KUB with or without Doppler. We can do that. But the best investigation is contrast enhanced CT scan of abdomen. Okay. Contrast enhanced CT scan of abdomen. Okay. This is the best diagnostic investigation. Sometimes we do MRI if there is some contraindication of CT scan. Otherwise, CT abdomen is the best diagnostic tool. Let us see how it looks in these investigations. If you do ultrasonogram QB, so see, this is the outline of this is the outline of kidney. Okay, you can see there's some central white area over here, just less, not much, and this is cortical area, and you can see a round echogenic mass arising from the kidney. I cannot tell whether it is a malignant or not. I can just tell you that there is a tumor. Okay. And if you use a Doppler ultrasonogram, then Doppler can give you slightly more idea. See over here, this is again the outline of kidney. Okay, outline of kidney is this one. You can see central whiteness. The central whiteness indicate the normal calcium system. This is cortical thickness is okay. You can see at one pole a round, mixed echogenic mass or hypoechoic mass at one pole. And same patient, when we use a Doppler give you idea about the vascularity. And cancer means they are usually highly vascular. So here you can see the vascularity is increased, especially at that tumor area. So we can guess this could be malignancy. This could be malignancy. Okay, this is very what do you say, like very cost-effective investigation, but it's not a good investigation because it can miss some smaller tumors. Okay, and we cannot say whether it is a malignant or not. So for better diagnosis, we always go for contrast enhanced CT scan of abdomen and pelvis. Contrast enhanced means basically we give contrast. IV contrast is used, obviously. Okay, see here, see the kidney. This is this is vertebra, you know that. This is aorta. Okay, this is inferior vena cava, IVC. This is aorta. This is vena cava. Okay, even you can see a renal vein is going to the. This is left side. This is right side. Okay, this is an axial view. Okay, you see there is no contrast in the kidney because kidney is gray in color. So, but what we can see over here is this is anterior part of the body. This is the posterior part of the body. Okay, you can see there's some irregular, okay, isodense or hypodense mass arising from the posterior aspect of the kidney, the right side. Okay, the right side. So see, and this is well outlined. Okay, it is not irregular. It's irregular, but the spread is not seen along the fatty layer, so it is still localized. Okay, and once this is when the IV contrast is not given, right? Now see how this tumor behave after giving IV contrast. See, this image is same patient image after IV contrast. What you can see over here, how I know IV contrast? See, the aorta is white now, so that means we have given the IV contrast. Here you can see the tumor become more brighter, like just like the normal kidney, those whiteness at the kidney surface. So this is known as contrast enhancement. That is, before IV contrast, the tumor was grayish in color, hypodense, slightly light grayish in color. After giving contrast, the tumor took contrast. This indicates that this tumor is very vascular, okay, and taking contrast. So whenever we see a kidney tumor which is hypodense or isodense, that's grayish in color, without contrast, become white after giving contrast, that is hypodense or contrast enhancement, and this is the classical finding in the case of RCC. Okay, remember that. Okay, so hypodense or mixed density mass in non-contrast CT with enhancement of contrast after in CCT is a classical finding of renal cell carcinoma. And CT scan will give you a lot of ideas, not only this. Number one, it will show you the size. Number two, it will show you the location. Number three, it will, okay, if you remember one thing, let me tell you. I think you have already studied pathology, right? So I think you know this thing, TNM, right? TNM is the way of staging. So whenever you do a CT scan, you can always apply, can I get these TNM information or not? T means tumor size. Yes, we can get the tumor size, the Software can easily calculate the tumor size. We can measure it by ourselves. Okay, tumor size and location, we can do that. And yes, the lymph node around the kidney is involved or not, we can see that. Okay, M means metastasis. Okay, so metastasis means we can see the liver for the liver metastasis. We can even see the lumbar vertebrae to see the metastasis, and we can also see the spread to the local areas. Okay, we can see that. And even we can see the inferior vena cava, very much important. See the color of inferior vena cava, it is still gray. So these tumors are still inside the kidney, they haven't touched the inferior vena cava. See, that means so many informations can be obtained by CT scan. That's why CT scan is a very ideal investigation to know all this information. Why we need this information? With this information, we can diagnose whether the cancer is localized, still inside the kidney, locally advanced, that is advanced to the surrounding area, including IVC, or metastasized, already went to the other organ like liver, lung, bone, brain, like that. So CT scan is important. Okay, remember that for diagnosis as well as to know some of the other features for management. Yeah, opposite kidney is also important, because sometimes the most ideal treatment of RCC, localized RCC, is nephrectomy, right? So if you know the opposite kidney, is fine, it's functioning well, there is no cancer in opposite kidney, then you can easily remove one kidney such that patient can survive with good outcome. That's why you should know the condition of opposite kidney as well. Okay, that can be seen in contrast CT of abdomen. MRI, do we do MRI? See, MRI is not done that commonly, but whenever there is a contraindication of CT scan, for example, if a patient has a allergy to contrast media, don't do CT scan, right? If the patient has, suppose, renal impairment, creatinine more than 1.5, don't do contrast CT. If if a person is pregnant, she's a lady pregnant, and developed RCC at around 45, 50 years, okay, 45, that area. So in those scenario where the CT scan is contraindicated, you can go for MRI. So MRI will give a similar image as CT scan. Okay, and one thing, MRI is better than CT scan. That is, if you want to see the inferior vena cava involvement, then the MRI is better than CT scan. So MRI is better than CT scan to know the inferior vena cava involvement. Okay, this is very important. I've already told you the most common way of metastasis is involvement of inferior vena cava. Okay, this is inferior vena cava. So the cancers will the cancer will follow through the renal vein and then inferior vena cava and then spread to the system, right? So to know whether the cancer has involved the inferior vena cava or not, the better investigation than CT scan is MRI. Okay, remember that. See, before and after the contrast in MRI, you can see similar pictures, right? So now, very commonly asked question is, what is the best investigation to know the inferior vena cava involvement? If you ask me, the most common investigation that we do, most preferred one, is MRI. To know whether there is an inferior vena cava involvement or not, the most preferred one nowadays is MRI. MRI, because see, in MRI you have to do nothing, just do an MRI and see the IVC. But if you want to, if you ask me, what is the best one? Best one means most accurate one. The most accurate one is vena cabography. That is, what we do is we inject a dye into femoral vein and take an image by X-ray. seems to be a bit primitive, right? Because why to inject a dye into femoral vein and again take an X-ray? Why not to do MRI? That's why nowadays we go for MRI or MR angiogram. Those are better options than IVC venacabography, where we inject a dye into femoral vein near the leg, thigh, and then take an X-ray of IVC, right? And you can see the involvement of these IVC. More accurate is that one, but more preferable one is MRI. So just see, so now clinically we always do MRI, okay, than doing the IVC, okay. But sometimes you get a question like, which is the most accurate? Most accurate is IVC venacabography, but most preferred one nowadays we do is MRI to see the involvement of vein. We can also do transesophageal echo, that is echocardiogram through the esophagus from the mouth. Okay, we can do that. That is usually done for uh, the inferior vena cava that is lying at the chest cavity. Very small amount of inferior vena cava is there, small length is there. For that we can do, but usually we do MRI of MRI angiogram for the involvement of vein. Okay, so remember these things. The last slide, then I'll stop for today. So, is there any role of biopsy or FNAC in RCC? Right. So, is there any role of FNAC or biopsy? But this is suppose you did a CT scan and you found that classical contrast enhancement, and you thought, fine, this is RCC. Okay. Now, as a general teaching, what we say, the most diagnostic investigation of any cancer is biopsy, right? We say that, right? But in some cases we don't do biopsy. RCC we don't do biopsy. Okay, we confirm it by our CT scan. But there are some situations where we need to do biopsy. For example, if CT scan, if contrast enhanced CT scan is inconclusive, but sometimes it is confusing. Okay, in that case, don't remove kidney with confusion. Rather do FNAC or FNAB, that is cytology or biopsy. Okay, if you are sure that the patient already has metastasis, that means if I'm sure RCC already has lung metastasis, suppose, how I can be sure? By doing CT scan of chest, right? So I've seen that the patient of RCC had metastasis to lung. Then please do FNAC. Now don't wait, because see why we don't want to do biopsy or FNAC. So when you do a biopsy or FNAC from outside by puncturing the skin, the danger of the puncture is these cancer cells can fall down in this tract and can cause cancer. This is known as seedling. So due to fear of seedling, we usually avoid FNAC or biopsy. But patient already had a metastasis, then don't fear about seedling. Why? Because before giving any chemotherapy or immunotherapy, we should know what is the type of cancer. Like, type means which type: cleared cell type, papillary type, chromophore type, like that. Okay. Number 3, suppose you are planning for a treatment like ablative treatment. Ablation means there are some situations where we give a local therapy like cryotherapy or heat therapy. Okay, in that situation you should know the histological type. You should confirm that it is an RCC. Otherwise we don't do ablation therapy. Local therapies like doing a cryotherapy to reduce the size. Okay, so before ablation therapy you have to do biopsy. Sometimes you're confused that could it be a cancer that is arising from other organ like colon. a colon cancer has went to the kidney, causing secondary cancer. If you're confused that this could be a secondary cancer because you have seen some mass in other organ as well. So if you think this is a case of secondary cancer, not a primary RCC, in that case also you can do a biopsy. So if you want to differentiate whether it is a primary or secondary, then you can do biopsy. See, so biopsy are not done if it is clean cut. Radiologically, if I know this is clean cut RCC, then we just straight go for surgery. Otherwise, inconclusive, confusion, do biopsy. Already a metastasis case, do biopsy. If you're planning for some local therapies like ablation therapy, do biopsy. And if you're confused whether it's a primary or a secondary, then go for biopsy. So these are the indications of biopsy. Then why you don't want to do biopsy? Because there's a very rare chance, not very huge chance, some chance of seedling and local spread. That's why we avoid biopsies usually. Now, okay, for any malignancy or cancer, we have to evaluate for metastasis. I've already told you, the cancer is dangerous because it not only damages the organ of origin, but also it goes to other organ and damage those vital organs as well. That's why you need to know these metastatic evaluation. Okay, so how to do that? See, as you know, the one of the most common organ to get metastasized is lung. Okay, that's why lung evaluation should be done always. So whenever you get a patient of a RCC, we always do CT scan of lung. CT scan is better than X-ray, no doubt. Okay, you can start with the X-ray chest, or better one is do CT scan of chest. Okay, because it will give you idea about the metastasis. CT is better than chest X-ray because it can even diagnose the smaller lesion in the lung, and it should be done routinely for all patients. Liver metastasis. For liver metastasis, see, we always do CT scan abdomen for diagnosis, right? The same CT scan abdomen will give you idea about liver. Plus, do liver function test, because whenever there is an extensive damage of liver, the liver enzyme may be elevated. Okay, you know that. Sorry. Increase serum bilirubin, increase ALT, AST, all these will give idea that there is an extensive liver damage. But yes, for liver metastasis, we already had done CT scan abdomen, that will help, and also liver function test. Should be done routinely, always. Alkaline phosphatase, alkaline phosphatase is an enzyme produced by various organ, and this is also produced by our bone. Okay, whenever the bone is growing, the osteoblast, they secrete these alkaline phosphatase. So what does it indicate? Okay, it indicates that the cancer in kidney, RCC. Okay, if suppose this cancer, if it goes to bone, okay, if this cancer goes to bone, then there's a damage of the bone, right? Osteolytic lesion, and that lead to release of these alkaline phosphatase. Obviously, when there's a damage, the new bone try to be formed, and in that time, these alkaline phosphatase are released. And these, so whenever there's increased alkaline phosphatase above the normal value, then we suspect there could be bone metastasis. Not sure, but we suspect. So once we suspect there is a bone metastasis by seeing the alkaline phosphatase raised, we can do other investigations like bone scan to see the bone metastasis. That's why alkaline phosphatase is a test that we do in our blood, right? So by doing a blood test for alkaline phosphatase, we can have an idea regarding whether there is a bone metastasis or not. Okay, so this should be done routinely. Bone scan. Bone scan, I'll show you what is that. It is an radioisotope scanning technique which focuses the bone of whole body. We inject the radioisotope into the IV, and after injecting that drug will go to the specifically to the bone, and they will show you the abnormal site in the bone. Okay, going to do that. See, whenever a patient of renal cell carcinoma present to you with bone pain, back pain, a patient of renal cell carcinoma with increased alkaline phosphatase, or a patient of renal cell carcinoma with evidence of bone destruction in X-ray bone or CT scan bone, in that case, you have to do bone scan. So I think you understood. So a patient with RCC, known RCC, okay, you have done the CT scan abdomen and you found patient have a feature of RCC. There's RCC. In that case, if you found bone pain, so you know patient has RCC and you found patient has a new onset of bone pain, or you found increased alkaline phosphatase, okay, phosphatase, or you found radiological evidence of bone damage, radiological evidence by doing CT scan or X-ray of the bone. If you found any of these, then always do bone scan. Bone scan will give you idea about the whole bone, okay, and obviously it will impact our decision making for management, okay. And other imaging depending on symptoms means, suppose a patient of RCC present to you with a chronic headache, vomiting, and seizure. Always do brain MRI. Do that, okay. So depending on the symptoms that we get, we can add other investigation as well. But the thing you have to do routinely are, number one, always do CT scan abdomen and pelvis contrast for diagnosis. Number two, for metastasis, you have to do CT scan chest or X-ray chest, okay, plus liver function test, including alkaline phosphatase. This much you have to do always, and remaining depending on the situation, okay. See, this is the chest X-ray. Of chest X-ray, you can see this round, see this cannonball, multiple radiopaque shadow. See, this is what known as cannonball metastasis. So if a patient with RCC, confirmed case of RCC, have this type of X-ray showing a multiple opacities, like round opacities, like cannonball, then this is undoubtedly metastasis to the lung. See the chest CT, okay, in different views, axial view and coronal view. You can see the hypertense shadow, okay, in the left lung. See, okay, small. So by doing a CT scan chest or X-ray chest, you can know about the metastasis. Better would be always CT scan chest. Okay, see, this is what bone scan look like after scanning. What is bone scan? So what we do is, this is the principle of any radioisotope scan. What we do is, we take a radioactive substance known as technetium-99, and we combine this technetium-99 with a carrier molecule. Carrier molecule means the carrier which take the technetium-99 to that specific place. As we know, we want the scan of bone. That's why we have to choose the carrier MDP. MDP means methylene diphosphonate. This is a carrier for bone. So when we don't mix it, it is found in mixture, okay. And what we do is, we just give this MDP technetium-99 intravenously. After that, the patient will be lying in the just like a CT scan bed, but the gamma camera will take image, okay. Because why gamma camera? Because this technetium-99 will release the radiation, gamma radiation, that is captured by gamma camera. And once we get the image looks like this one. Why it look like this one? Because this MDP, the MDP molecule, this carries the technetium-99 to the bone. Okay, and once it reaches the bone, it will be concentrated on abnormal site like cancers. So what you see is, you will see hot spot. Hot spot means, we say hot spot, okay, hot and cold spot. Hot spot means the dark spot. These dark spot indicate increased activity of the bone. And if a patient has RCC, and if you found this type of hot spot, black spots in multiple area of the bone, this indicate bone metastasis. Okay, so see over here, this patient has metastasis to a lot of bone. You can see the hip bone, okay, right side, see upper part of femur, the left humerus, see the sternal bone, even you can see the shoulder joint, you can see the ribs are involved, even the hip line are involved, even the skull is involved. So you see the vertebra, this is the back view. You can see the thoracic vertebra is completely involved. Okay, so this patient has a multiple metastasis to the bone. So if you found a patient with RCC, okay, and multiple metastasis like this one, then this is a case of RCC with bone metastasis. Okay, so do we do bone scan every time? No, we do bone scan only when we get the suspicion of the bone metastasis, like RCC with new onset of bone pain, back pain, RCC with increased alkaline phosphatase, RCC with evidence of bone destruction in X-ray or CT scan, which gives us idea that could be a bone metastasis. Then we do to see the entire bone mapping in bone scan using technetium-99 MDP. This is the name of drug. Please remember that. Okay, we use this technetium-99 MDP for bone scan. Okay, and this is the image. And what we look for? We look for hot spot. Hot spot. Hot spot are actually this black area in the bone. I hope you understood.